Could you tell us about the trial that you're presenting?
Yeah, it goes back to 2004 when the new studies on docetaxel came out with a survival benefit in metastatic disease in prostate cancer. When we looked at breast cancer and colorectal cancer, this also transferred to a benefit in the adjuvant setting after surgery. So our idea was to test docetaxel adjuvantly after surgery for high-risk prostate cancer. So that's why we started a trial back then in 2005. And then we randomized the patients between 6 courses of docetaxel, Q3 weeks, and the control arm was surveillance only. The endpoint of the study is PSA rise to 0.5 or higher, above 0.5. And we have followed the patients for at least 5 years now. We recruited from 2005 to 2010, and then we have followed the patients until 2015, and then we have analyzed our data. So that's what the study is.
And what results are you finding?
The finding from the study was, surprisingly, that surveillance had a trend to be better than docetaxel treatment adjuvantly for prostate cancer patients. The p-value was 0.07, so it's quite close to be an advantage for surveillance. This is the first time the study has been conducted with docetaxel only, without hormonal treatment, and also without continuous corticosteroids. So this study differs from any other study that has been published, you can say. So these are new data, and what we saw was that initially in the docetaxel arm the progression rate was lower. So it was a better outcome at the beginning, but when taxanes was stopped, there was a quite dramatic drop in the experimental arm. The number of progressions were high, from approximately 6 months to 2 years. And then beyond 2 years, the curves were parallel to that in surveillance, but at a 10% lower level. So how should we interpret this very strange result? Because the curves are crossing, obviously. Well, we have discussed that a lot, and there are some theories, hypotheses, to explain this phenomenon. And we believe now that what we see is a subgroup of patients where the cancer is stimulated by the taxane treatment in some way. So we will see a higher progression in a subgroup of patients. And how come? Well, if we look through the literature, there are references describing how prostate cancer stem cells can do a symmetric cell division and they divide themselves and become more stem cells. And these stem cells then go through asymmetric cell division when taxanes is removed, and give rise to differentiated tumor cells that produce PSA. So this could explain why we suddenly, after the taxane treatment, observe a very rapid increase in PSA-producing cells, giving a PSA value above 0.5. The second explanation that we can come up with is that the taxane treatment, the docetaxel treatment, gives rise to an elevated level of repair genes of the DNA. So the damage from the docetaxel treatment to the DNA is repaired by these enzymes, and thereby there is a quick recovery of these tumor cells.
Well, I suppose the question there is, what does this do to docetaxel therapy?
Yeah, I think it's a kind of resistant mechanism that we observe. And why hasn't it been observed before? That's the question. Well, I believe that as I said, most studies have hormonal treatment parallel to the docetaxel treatment, and then you mask the PSA, rising PSA. So that's why it hasn't been observed before. And how can we see survival benefits in metastatic disease, because that's well known? Well, I think that in the metastatic setting you have a lot of tumor cells that are differentiated, more or less. And these cells are responsive to docetaxel treatment, most of them. And it depends on the number of cells that are non-responsive to docetaxel treatment in the total tumor burden, on what response you will get to docetaxel treatment. And we know that the response rate is approximately 50%.
Well, it sounds like it raises more questions than it answers.
I agree. As I said, we were surprised by the finding. Sometimes that is research. And now we'll have to do further analysis of this subgroup, try to identify it, and then do analysis of the characteristics of these cells. So this is the next step in what we plan. And we also plan, of course, to see if this first endpoint, biochemical progression, transfers to a worse prognosis regarding metastatic free disease and also survival. So it's important to follow this cohort 10 years and maybe 15 years as well. It raises a lot of hypotheses that has to be proven, but it's anyhow it's new data. It hasn't been observed before.